And my slides are showing and everything looks good?
Looking good.
Okay. We've been through a lot in the past couple years as a community, as a society, as a planet. That gave us a little bit of time, I'm sure all of us, to sit back and reflect. And so we've been busy at work at Precision Point Diagnostics through some of these periods and really put our nose to the grindstone in terms of some new development. So today I want to talk to you about the science of food, how we're lowering that inflammatory load through lifestyle. And I think that this is very foundational to all of us. And when we have patients that come in and they say, well, I don't know if I can do that, or maybe I'm sensitive to many things and I can't take a certain supplement, and they have all these concerns, and what most of us would probably say is, then you need to really focus on food. And even if they can do everything, even if they can go to Whole Foods every single day and they can take every supplement and they can exercise and they can do their 10 minutes of HIIT and they can get their steps in and they can get their meditation in and so on and so forth, we would still say, if you're not going to change the diet, you're not going to have the most optimal outcomes. This just hit me in the face early on as a brand new practitioner. And I remember just, working under people and watching them and thinking about the practitioners who are getting the most change with their patients. And some were very evidence-based and more to the Western side and very effective with what they were doing. And some were more drops of botanicals and energy medicine, but still effective in getting patient change. And so when I looked at these wide varieties of how we can treat people, yet still see optimal outcomes, the thing that I saw in common with those practitioners is that they were making aggressive dietary change. And so as soon as we talk to our patient about we need to make some dietary change, of course, the next question is, well, what should I eat? And if you track the news, you see a lot of good things about the Mediterranean diet coming out in this past week. And when we walk through the data, we see absolutely wonderful data about ketosis and ketone bodies in the brain and being anti-cancer and mitochondrial biogenesis. Or we may have certain patients that are very sensitive and need more of a FODMAP diet or a low histamine diet. And all of these approaches are worthy, but they still aren't individualized. And so one of the best ways to get an individualized answer to that is to take the history and then look at reactions that are happening in your patient. And so we're going to walk through more of that science around of course, not just IgE, because no matter how good the IgE test you do, only 50% of the time is there a positive titer when there's a symptom to a food. So that means 50% of the time it's something else going on in the body. And when I first started working with food allergy tests, which is a good 20 years ago, working in laboratories a good 20 years ago, and asked to maybe write a paper about things like food sensitivities. And when I would go to PubMed and look for information about food sensitivities, you could find some data, but it was far and few between. But since that time, if I do that today, and you're going to walk through some of that with me today, if we walk through current research in terms of IgG food sensitivities, it is not just picking a couple studies here and there. It is very well documented, very well represented in the data. And so when we work with our patients on things like leaky gut and food sensitivities and even allergies, and they go back to some other practitioner, and that practitioner says, there's no data about that, that's made up. Categorically, that is not true at this point in time. There's absolutely good science around looking at not only allergies, but sensitivities, and even better science when we begin to drill down into IgG and look at some of the differences within. Some of the pushbacks you'll get are things like IgG antibodies are different, or maybe IgG4 is the only one that should be looked at. And we're going to walk through some of that conversation and really look at what some of the science says. Also, draw your eyes to this picture upon my first slide here. And I want to introduce you to our new blood collection tool. And again, I'll speak more to this, but the test that we use at Precision Point looks at 88 foods and 4 ways the immune system reacts to those foods. And this can be done by standard blood draw, but we know many times it's hard for the patient to schedule the time to come into the office to get that done before we see them. So we have those results at the patient visit. So this is a blood collection device that can be done by the patient, by themselves at home. And if you'll notice the tips look much like a Q-tip. And so you're right, that is what is going on here. And so activity that's much like a sponge at the top of this, and then using capillary flow like a pipette for these individualized tubes. So they do a very tiny stick, one of the smallest needles used in any type of finger stick anywhere. But then because of this activated tip with this capillary flow technology, that we're able to get 30 microliters of specimen into each one. You see 4 tubes. This allows us to run the 4 various reactions that we're going to talk about. I just wanted to introduce that quickly before we get started. And I do want you to know, if you have to check out early, there are going to be some promotional introductions for being here. So hang out or make sure you listen to the recording for getting that. It's our way of saying thank you. We appreciate the time that you spend with us to learn more about how to help your patients get better. So what we know is that allergies and autoimmunity are radically increasing. Pick your favorite autoimmune condition and go look at the incidence in the past 40 years. And allergies are no different. And so this is looking even just at IgE, allergic reactions. And what we know is that the environment is creating a very challenging place for the immune system, creates lots of immune confusion. And we've seen as much as a 3-fold increase in the US in the last decade, a 50% increase in allergies between 1997 and 2011, that things like peanut or tree allergy have tripled in a short amount of time. And when we think about that amount of time, that is not enough time for genetics to change. So autoimmunity has skyrocketed, allergies have skyrocketed, environmental toxicity is a part of it, and contaminants in general. We all know this story that even the best bread today is not the bread of the past. We use preservatives in it. If we pick up anything that has benzoate in it, that's an irritant to the gut. If our cattle is treated with antibiotics, that changes the microbiome. All of these things have contributed to weaker gut lining and more incidence of allergies. Now, an interesting thing about that, however, is we're going to look at some data that says even though allergies have skyrocketed, you're not seeing a big change in incidence in some of the traditional methodologies that are used. So some of the larger labs use a technology called Immunicap, and it's just not very sensitive. So even though we know the presentation of symptoms is showing up more and more in the doctor's office, if you looked at lab results from those places, they haven't really changed. So what that tells us is there's a lack of sensitivity, and we need to look for other methods in terms of analysis. Now, the people often what is said when we hear people push back in terms of IgG sensitivities is they'll say, well, that is not in the research. And again, A, that's not true. And B, before I even get to the research, if I open up my immunology book, I will find types, just descriptions of hypersensitivity reaction. And yes, description of type 1 mediated by IgE, and what we know is that this should happen when you're presented with an antigen, but sometimes the immune system gets confused and does this in a response to a food, which it shouldn't do. That creates this mast cell activation, which releases histamine and creates these various symptoms. But right there in the immunology book, we know these reactions are not limited to IgE, but they're mediated by IgG too. And so in the same way immune confusion happens with allergies, of course it happens with other antibodies as well. And when we continue to drill down in terms of capturing various types of hypersensitivity in the body, we see that when we begin to add to the story things like IgG, or when we begin to add to the story various cytokines, things like complement, we will capture a more robust picture of where the immune system can become activated. And then also, if it can become activated in those areas, it can also become confused in those areas as well. So a standard immunology book will tell you that there's not one way that this occurs. And so here is a picture, a graphic that we are all very familiar with at this point in time. And so what I want to share with you is what we see when the body is intact. And so we're used to thinking about when the gut becomes more leaky. This is when those naive T cells get activated. They become humoral cells that create antibodies, and it creates more disruption in the gut. That will create changes in diversity in the microbiome because of the histamine that is created, and that will create this feed forward process. When we have less histamine and more things that we need in the gut, like a diversity of the microbiome and appropriate levels of fiber. Again, that helps us to create things like short chain fatty acids that come down here and blunt inflammation. But once the gut becomes leaky and these T cells become activated, then what we see is the inflammation interferes with our ability to do things like make these short chain fatty acids, which have direct anti-inflammatory activity in the body. A misconception that can occur is that, well, I don't need to look at food sensitivities in my patient because I know they have a leaky gut, so they're just going to react to the foods that they eat. And so therefore, testing would not be useful at this moment in time. And while, of course, leaky gut is a major mechanism by which we become confused and reactive to foods that should be nourishing for our body, it's not the only way that that occurs. So if bits of food reach this Peyer's patch and we do not have adequate immune signaling in place, it will tell the immune system. So if we have poor secretory IgA, for example, if we're not making immunoglobulins like we should, when foods hit this Peyer's patch, the body says, something is going on. My immune system is down. Maybe it's this food that's creating it. And again, it will begin to create an immune response to it. So it is not only leaky gut that creates a response to foods. It is both immune confusion in the Peyer's patch as well as leaky gut. And those of us who work with food sensitivity tests know this to be true. We know that if we said, yes, I know my patient has leaky gut, I'm going to look at foods that they are reacting to, we would not necessarily see the top 5 foods that they eat create the top 5 reactions. And that's because it's not quite as simple as just leaky gut, but there's this other immune cueing that's going on at the same time. So in addition to that, and then so again, also, even if leaky gut is the reason for many of those foods becoming, our body becoming more reactive to them, removing them allows the gut to heal. And so knowing which ones you're reacting to the most is going to allow the gut to heal the most quickly, and it's going to move the patient away from symptoms more quickly. So the question becomes, well, do I always need to do a food test on every single person? And there is never an answer in medicine, except maybe this is a never answer. There's never an answer in medicine that's an absolute, except there are no absolutes. And so, no, of course, not every single patient, but when we are working with can we get a lot of good information from an elimination diet, like gluten removal and dairy removal? Absolutely, we can. But when we are looking to create the least inflammatory diet possible, looking at where a person's immune system is reacting allows us to do that. Jace mentioned that I'm the educational director at Progressive Medical, and Progressive is a large integrated integrative clinic, 15 practitioners on staff, all working together. And we rely very heavily on food sensitivity and allergy testing. But yet we still combine this with things like a detox diet. So for example, people come in, we know that it's a food first environment to get people well, get people started on a detoxification diet, do a blood draw or have them do their stick at home. And then when they come back for their next visit, we have those results. So now we're able to individualize that detox diet. We're able to customize it to what's going on in their body. And so, yes, traditional elimination diets will give us a lot of information, but you tend to remove the more inflammatory foods. And many times you're going to find that it's something odd that you wouldn't have expected that's a trigger for a patient. Remember working with a colleague who the test came back showing sensitivity to cantaloupe. And she said, well, I eat cantaloupe and nothing happened. So I'm not sure about this result. Meanwhile, she did have fibromyalgia and she was not able to get good control with it. She was heavy practitioner of functional medicine, using, SAMe and mitochondrial therapies, and had done various elimination diets and done things to improve her thyroid, but still not seeing the results she would expect. Fast forward, one day she's processing a lot of cantaloupe and she's peeling it and freezing it. A harvest had come in, and she looks down and her hands are blistering. And at first she's thinking, well, maybe there was something on the cantaloupe, but they were hers that she was harvesting. And so no, that can't be it. And so then finished what she was doing, went out and bought cantaloupe and did the same thing again to see if the same thing would happen again, as a good scientist working on her N of 1, and saw the blistering again. So when she pulled out the test results, went back and looked at them, and now made the dietary changes that were there. And when she did that, she said this was the first time her fibromyalgia began to go into remission. So this speaks to the fact that sometimes it can be these odd foods that we wouldn't suspect. It also speaks to the fact that there are less sensitive tests out there, and they can miss things when this occurs. So we pride ourselves in our ability to pick up even very low levels of reactions, so you can pick up the full spectrum in terms of what's going on. We know that food allergy is a growing problem. And here, even the Allergy Asthma Clinical Immunology Journal talks about how we need to change the recommendations. And they're saying, we say remove foods for a period of time early in life, but we need to change that. And so you'd think with allergies and sensitivities increasing, the change in recommendation would be to keep foods out for longer. But in fact, it's not. It's to keep foods in, it's to begin to introduce at an early period of time. And interestingly, doing that in a way when those immunoglobulins are still present. So immunoglobulins like the ones in breast milk. So when we see good immunoglobulins, whether or not it's our secretory IgA or something passively coming to us, we're more likely to form an immune tolerance to that, and especially when the microbiome is in place. And this also speaks to why we want to remove the most inflammatory foods, because as we reduce inflammation, we allow that microbiome to heal. And very interesting research here where they took kids who are sensitive to peanuts, actually allergic to peanuts, and had them avoid them over 18 months while doing desensitization. One group got lactobacillus, the other group did not get lactobacillus. And what you saw was in the group that got lactobacillus, there was 4 years, they were able to tolerate peanuts even 4 years after stopping the desensitization treatment, whereas the group that did not get the allergy, did not get lactobacillus, they did not see that same level in terms of holding. So only 4% were still in the group that did not get lactobacillus. Only 4% were able to tolerate peanuts, whereas 4 years out, 80 to 70% were still able to tolerate it. So removing foods that we're sensitive to reduces inflammation, that allows the microbiome to take back over. And this is why we think about this test as not is not a food removal test. In fact, we think about this test as a gateway to get our patients to being able to eat even more foods without having reactions. Now, there's probably a couple of foods out there that we never want to see sneak back into the diet all the time, always, and in some patients, keeping them out completely. And gluten and dairy are probably two examples of that. But when we get that food test back, or we have that patient who says, I can't eat broccoli, I can't eat beans, I can't eat so many things that are out there. The goal of this test is to remove those foods for a period of time, but then use it as a challenge to bring those things back in when the gut has been allowed to heal by first removal and then doing your other therapies that build a leaky gut. So, for example, gluten is, one thing that is confusing to us, that we know patients will go to Italy and they'll say, I ate the bread, I ate the pasta, I didn't have any of the problems that I have here. And one of the issues is that we use a different gluten here. They use more durum wheat, and we use a different species here that is lower in a decapeptide that breaks down gliadin. But check out this study. Celiac patients, and in these celiac patients, they had them eat wheat, right? That's counterintuitive to our clinical brains, but that's the way research works. One group got probiotic, the other group didn't. And the group that got probiotic was able to tolerate the wheat when introduced, because the probiotic, and it's a bifidobacter, has an enzyme, prolinidopeptidase, that breaks up the gliadin. So even though we know somebody might be sensitive to wheat and or other foods, when we take it out, it allows the microbiome to take over. When the microbiome takes over, it creates signaling that makes us more tolerant. It produces enzymes that break down these antigenic foods. And so eventually we can see people tolerate, maybe not 3 times a day, but bits here and there, even of something like wheat. Again, there are going to be some patients where I'm going to say never, ever. But the goal is to get people back to more normalcy of life, not to put them in the other direction. And I think when we explain that to patients, we can get a lot more buy-in. So what we know is the paradigm is shifting, that even allergies aren't permanent. And so that's going to fly in the face of something that you probably learned back in med school, or even what we're kind of counseled to believe and think. We're led to believe, oh, okay, IgE is forever. Actually, half-life of an IgE antibody, 2 to 4 days. Our body tries to get rid of those quickly. If you get stung by a bee and have an anaphylactic reaction, we want to get rid of those things quickly. So if it happens 2 days later, it's not just as bad. And now you're going, but wait a minute, what about the little kid who has a peanut allergy, a very bad reaction as a kid, 20 years later, has avoided them all this time, and now again is exposed and still has that reaction? Well, true. Titers from different people will stay elevated for different periods of time. And this is true for allergies. This could be true for infections like COVID. Maybe you know someone who's had an infection and, that was the only one they got. Or maybe you know someone who had it and they got it again in 2 months and 2 months later kind of thing, because titers stay elevated for various periods of time. And if you have a genetic predisposition, it can stay elevated for longer. But the standard of care is not that if you have an IgE allergy, it's not that you have to keep it out of the diet for the rest of forever. In fact, reintroduction is now more commonly considered. It would still be done under the supervision of the physician. It would still be done with an EpiPen present kind of thing. But what we realize is even allergies aren't permanent. If you do things that increase IL-10, and so, for example, it's a couple ways of increasing IL-10. Omega-3s do that. Probiotics do that. And so we know that we can even shift IgE response. Oh, and decreasing a leaky gut will also improve IL-10. So, and what we also know, again, is IgE only has a positive titer 50% of the time when there's a symptom, so it's not the entire story. So We need a next generation of testing. We can't, it's like lipids, right? We're not happy sitting around just looking at cholesterol. We want to see LDL. We want to see HDL. We want to even see particle size of LDL and HDL. We want to know how buoyant it is. We want to know if it's oxidized. We want to know the size and the shape, because when we have learned more about it, we know those are the things that really dictate whether it forms a plaque or not, just not whether cholesterol is present. And the same thing is true in terms of reactions to foods. It's not just an allergy, but it's a sensitivity. And there are other things that modify those ideas as well. So looking at multiple ways the immune system reacts becomes a much more thorough approach. Okay, so what do I mean by that? And so whether or not you collect through serum or through the finger stick, this is what the results look like. And very excited to share some changes that we've made and some developments, and really just talk about how all of this works together. So what I mentioned is, if you look at some of the standard ways, you just send out quick serum to, a larger lab and get a result back, and they go, but I know I always react to clam and it comes back negative. It's not a surprise. It's not a very sensitive test. And, I'll share the reference in here where they talk about incidence of allergies has gone up, but the incidence in testing has stayed relatively the same. So it's not matching what's happening in the population. So let's say on our test, what we would expect is a high level would match a RAST level where you would begin to see an overt symptom. So, okay, well then if only the high level is the immediate symptom, but still, even with the best IgE test, you can expect that only 50% of the time, because that's just the cards of IgE. That's just its personality. So why report the lows and the highs? Well, the reason for doing that is because when we can begin to see lots of presentation of IgE, when we begin to see many reactions in this direction, we know, oof, you're getting a little bit more Th2 tipped, more in that autoimmune direction. We need to do things that increase IL-10 because it will decrease Th2. And so that leads us to say, you're getting a little more atopic, maybe more kind of pre-autoimmune. So yeah, let's think about, again, some probiotics. Let's think about, some omega-3 fatty acids. And in fact, desensitization increases IL-10 as well. Not going to be readily available, but breast milk has IL-10 as well. And the reason is because IL-10 tells the immune system, slow down, recognize this is normal, quit being reactive to it. And so this is why we'll often use things like immunoglobulins, things like Ig or even IgY, because these immunoglobulins will duplicate what's done in breast milk and really help to begin to form more of a tolerance. So, if the test has the pages that show the exact reference ranges in the back and the raw numbers and the data, but what we thought would be more helpful to you, the clinician, is not a raw number, but how reactive is your patient? So we've all had the patient who has just never seen a dietary change a day in their life. If it's green, they haven't met it unless it is, maybe a Skittle or a Starburst. But in terms of a vegetable, very foreign to them. And maybe they come back with lots of reactions. Maybe they already had lots of reactions and they just feel overwhelmed by the whole thing, and they don't really know what to do. So one of the things that you'll always see from us are changes and different ways to look at it. And when you talk to us about, this would really be helpful for my clinical interpretation, we take that to heart and we work with those changes that you're suggesting. So practitioners, thank you, Connie, one of the first to bring this to my attention. She said, this would be a lot better if I could see the percent reactivity. So we made that change. So now when you're looking at the moderates and they're really falling apart, well, okay, I want you to just stay away from the ones where you are 70% and up. And so you can quickly see which ones are more their problem areas and which ones, if they're forced between 3 things that are on their list, and then they can know, okay, well, this is my lower level reactivity. So that would be a better choice for me. So we changed that. Also, we did a little bit of changing with the color and the graphics here. Let me explain that to you as well. So one of the criticisms of IgG is that they are not all alike, that there are 4 types, IgG subtype 1, 2, and 3, and IgG subtype 4, and they don't all behave the same. And so if you're just looking at them all together, it can confound the picture. And that is a very valid criticism. So IgG subtype 1, 2, and 3, they bind to complement, they create inflammation. Fascinating. If you have enough IgG antibodies, they can even bind to receptors where IgE was going to bind. So we have this idea that IgG is 3 to 72 hours later, and that is typically the case. But if they have a super high amount of IgG, it can even displace IgE and create an immediate reaction as well. So these divisions that we have in the immune system can be a bit more gray than absolute black and white. But IgG4 doesn't do that. It doesn't create inflammation. It doesn't bind to complement. It doesn't create an antagonistic an agonistic effect in the IgE receptor. In fact, just the opposite. So IgG4 is a little guy. It's a different shape. It's a different size. It has different binding affinities. It doesn't create inflammation, but it will go up over time. And if we're lucky. And if it goes up, if there's more IgG4, greater total number than IgE, then it will block IgE and you will have tolerance to that IgE reaction. So in the case of clam here, clam is high, but IgE is low. And so you have not developed a tolerance yet. You still need to be careful with this reaction. However, if the reverse were true, if you had a high IgG4 and your IgE was lower, it creates an immune tolerance. And there's actually a substantial amount of data around this. And in fact, it comes to us from the desensitization literature. So if you are prescribing desensitization injections or sublingual immunotherapy, the whole intent of that therapy is to increase IgG4. It's not to decrease IgE. When we give little bits of the same thing, it doesn't decrease IgE, but it increases this IgG4, which will bind to the IgE receptor and block IgE from binding. And now, if IgE cannot bind, it can't trigger that mast cell to burst open and release histamine. It can't trigger that basophil to burst open and release histamine. IgG4 is the shield here. Also, IgG4 will increase IL-10 and cause the level of these reactions to go down. Well, why? And what's you know, we've all seen this and we've wondered. Our patient will come in and they'll say, you know, we'll say, do you have any reactions? And they'll go, well, yeah, I had a dairy allergy as a child, but I grew out of it. And we go, can that really be true? And absolutely. So when we start to have this immune confusion, this IgE reaction, in that case to dairy, the body says, but I don't want this. I don't want to die from dairy. And I don't want to die from a strawberry or peanut. If foods made us react and created this anaphylaxis, we would not be a very successful species. And I would argue that we're a pretty successful species. And so the body said, let's figure out a way to become immune tolerant. And so this happens with viruses, and this happens with bugs, and this also happens with allergies. The body says, nope, calm this down. Let's convert into IgG4. We'll still have a little bit of memory of this, but it's not very inflammatory. And in fact, it can block a lot of this inflammation from occurring. So IgG4 creates a tolerance. It's good most of the time. But there are a handful of times where IgG4 can drive certain conditions. Most of the time it's good, but there are a handful of what are called IgG4 related diseases where in those conditions there's immune confusion around IgG4. These the top ones tend to be eosinophilic esophagitis, autoimmune thyroiditis, and conditions of the ovaries and the prostate. So just think reproductive tissue and esophagus. And the way it's problematic is not the same way you're used to. It's not by increasing complement activation and more cytokines and more immune recruitment. It's kind of just like grit and gravel, just that IgG4 starts to precipitate out. There's just so much of it. It starts to get into tissue, and the tissue that it more easily gets into is the esophagus, the thyroid, and the reproductive tissue such as ovaries and prostate. And so you don't have to memorize all this. There's a physician's guide that we have, and it's a nice 15-page booklet. It's got information about, for example, which conditions are more driven by IgG4, which conditions are more driven by complement, when is there more worry about sensitivities versus allergies. It's a great booklet to get your hands on because it's got a really nice section on cross-reactivity. Both food families, like you're thinking of, maybe your patient loves rose hip tea and we don't test rose hips here. And so you're wondering, okay, well, do they need to take that out? You can look at the food families to see what food family that rose hip tea is in. Interestingly, there's also a nice, not even just food family, but cross-reactivity lists between the environment and foods as well. So maybe you have a result like this and they go, clams, I hate clams. I wouldn't eat a clam if you paid me. I had one back when I was 6 and it was disgusting and I'm never eating that again. Why am I reacting to that? Well, clam has a very high cross-reactivity with cockroach, and we know that's a very common environmental allergen. No, people aren't eating cockroaches, but the breakdown particles, the dust, like the dander, gets into the air, we breathe it in, we become reactive to it. So like banana and latex cross-reactivity. One that's fascinating is they come back reactive to beef and they say, I'm vegetarian, I never eat red meat. Cross-reactivity between tick bite and beef. And so grab that booklet, email us for it, and because it's got some real helpful information in there like that. How about this? I've been off gluten for forever, and yet this test still says my antibody is high. Why is that? We'll go double check what their antibody is to Candida. The Lancet talks about a cross-reactivity between the hyphae wall of Candida and gliadin. There's a similar amino acid sequence. So you could get rid of gluten, but if you leave the yeast, it will perpetuate making these antibodies because of that cross-reactivity. And so that's one of the reasons we include Candida on here. Of course, your patient is not sitting down eating a plate of Candida, but it has so much influence in terms of allergens or sensitivities like gluten that we wanted on here. A second thing that happens if you see a big reaction to Candida, a large immune reaction to Candida, that tends to mean that Candida is there. So long-term Candida puts out proteases that chew up secretory IgA. That's the first line of defense in your gut. If secretory IgA goes down, the rest of the immune system goes on high alert. And it says, oh my gosh, our first line defense isn't there. So when secretory IgA goes down, that means the rest of the body ramps up to do the work it's not doing anymore. Up goes IgE, up goes IgG. And even though you remove these foods, those titers stay elevated longer than normal because they say we have to. Our first line defense isn't doing what it should do. And so this can be another reason when titers stay elevated, even when someone's done a really good job of food removal. Now, that idea that IgG4 gets teased out. First, it creates tolerance. Most of the time, it's good. Second, there are a handful of conditions where it's responsible for the condition. But third, it gives you a much cleaner picture with IgG because IgG4 is not inflammatory and it doesn't create delayed sensitivities. And so, but then you might be thinking, but I know some labs that only measure IgG4 and talk about it as a sensitivity. Why do they do that? Well, They do it because of research, but they do it because of research that's a good 15 or 20 years old by now. So back in the day when IgG was even less accepted, um, we began to see, IgG4, it kind of roughly mirrors IgE. Like often where you see these increases in IgE, you see this increase in IgG4 as well. So maybe that's the one we should be looking at. Maybe that's the sensitivity. Maybe we can get this one to gain more traction in scientific communities. Well, we were on to something, but not onto a better sensitivity. IgG4 would go up and mirror IgE because this is how we create tolerance to it. So, so teasing it out is good because you can see if you're tolerant to an allergy, but lumping it in and not discriminating can confound your IgG picture. So our total IgG is predominantly subtypes 1 and 3 because those are majority of the ones that we make. Some people say IgG only responds to protein. That's not true. Type 2 also responds to polysaccharides. So you do see reactions across various types of foods. But again, IgG still isn't the entire story. So we've all had patients who have that migraine, and IgG is moderate for dairy and cauliflower, but high for broccoli. And they go, no, broccoli never does it to me, but dairy and cauliflower do, but those are moderates. What else is going on? Well, the same was noted in the polio research. Just because you had the highest IgG titer did not necessarily mean those were the people that had the most symptoms. So the researchers said, okay, what else is going on? And what they found was that when complement was present, this would bind to IgG and amplify the reaction 1,000 to 10,000 fold, really creating, I talk about wonder twins activate, form of a super inflammatory reaction. So it's not just IgG, it's do you have IgG and complement, because these are going to be the most inflammatory reactions. So when we look through a result like this and we see a moderate result here, but yet also a pretty high level of complement, these can be when we know we want to be more concerned. And you're not going to need to like necessarily really think hard about these algorithms, because I'm going to show you how the diet, how the elimination diets do this for you and really simplify a lot of that work. Now, what about if complement is there and there's no IgG present? Well, then it's really not as much of an issue because it needs to bind to something. And so just by itself, but still, if we see a lot of complement floating around, we go, that's not the greatest. Let's calm down some inflammation. And your curcuminoids and your fish oils can be really helpful in just calming down some of these inflammatory reactions as well. So even outside of food removal, this tells us a lot of direction. Are you more autoimmune tipped? Have you developed tolerance to your allergies? Do you have a lot of sensitivities? How bad are those sensitivities? Are you amplifying those sensitivities? Do you have a lot of complement? And so it gives us a lot of clinical direction. But with a lot of clinical direction and a lot of information comes a lot of questions from patients and a lot of things to sort out. So then we just say, you know what? Here's two diets. The less restrictive, that removes high levels of foods, and the more restrictive, that removes highs and moderates. And the algorithm's written right up top. So again, nothing to memorize. So we take out the high levels and then we rotate the levels that are moderate with that and also have complement present. So you get a nice reflection of that. And so what many people will do is if somebody has rapidly progressive, very inflammatory symptoms, then we want to have the least inflammatory diet possible. So we start with the more restrictive diet. Maybe somebody's just got elevated antibodies to their thyroid. They're not very symptomatic. So we think, okay, and they've never done dietary change in their life. We could start with the less restrictive diet. Or another way to do it is to start here. And then as they get better, to move them down. down to a restrictive diet. Also, some other things that people will do is they'll say, okay, I want you to remove these for longer, more like 6 to 9 months, and remove these for 3 months. And in 3 months, you're going to begin to challenge these. And after a period of time, we'll work through from your least reactive up to your most reactive to challenge these foods. So again, this is meant to be a challenge test. Now, one thing that I always do find useful when we're presenting this to a patient, glass half full. So don't show them the reds and the yellows first. And I learned this from a wonderful colleague, Lee, and she taught me you want to show patients the more positive side of things. She said, Cheryl, fold the page in half. Show them all the things they can eat. Is there anything on this list you like? Oh, yeah, I love turkey. I love watermelon. Oh, yeah, I love corn. Great. You're going to concentrate on those foods. And now here are the things that you're going to take out. So just a little bit of psychology around it, because of course nobody wants to limit their diet for forever. And again, emphasizing that this is to calm down gut-based reactions. So if you really are stringent about this removal and you do it, very mindfully, what should happen is within 6 to 9 months, you should be able to reintroduce foods and tolerate more foods, not less foods, after doing something like this. So we give you two diets. Some people would say to me, well, shouldn't you even get rid of the lows? Sure, the most clinically anti-inflammatory diet is to get rid of anything where there's a reaction to it. But we're trying to, like Goldilocks, strike that middle ground, not too hot, not too cold, just right, making sure there's still some foods to eat, and getting rid of the things that are most inflammatory. But you can always look at those percentages and decide exactly how at what level you want that removal to happen at. So it gives you a lot of opportunity for individualization. Then 4 types of antibodies. One takes reactions away, one amplifies more. So this is our proprietary formula that looks at a total combined allergic reaction. And so again, that difficult patient who's just struggling, you could say something like, you know what, when we look at the overall antibody total, these are your most reactive foods. Just focus on the top 10. Just another way to say, okay, what are your real problem areas, and how can we make this clinically meaningful for you, so that compliance still occurs. This is more second round therapy. First, I would just take out the things they're more reactive to. But then I think it's also nice to know, well, of the foods that you are reactive to, do they have other patterns in common? So then we take those foods that you're reactive to and we run them through this lens of, well, were they high oxalate foods? Are they high in glutamate? You can see how this would be really helpful for your migraine patients that could be more amine activated or histamine reactivated, or you might go, okay, we started with food elimination. You're still having some issues, but it looks like you have a lot of issue in terms of FODMAP style food. So maybe we'll do a low FODMAP diet, but this really keys me off into the fact that I've really got to include digestive enzymes for you as well, because basically the reason we become more reactive to those foods is because we can't break down sugars and starches. And so making sure we get those enzymes in place. Maybe I see that they're reacting to a lot of histamine foods, and so I say, okay, I want you to also include diamine oxidase, the enzyme that degrades histamine, as part of your leaky gut protocol. And so just gives us one more lens by which to examine why and how our patient is inflammatory. Then we're not looking at every food. We're looking at 88 foods. And we used to look at over 300 foods. But what we found was that really less than 2% of the population reacted to those foods that were out of the top 88. And so we decided, rather than a test that would be more expensive, then let's limit to where people really are reactive. And let's look at the multiple ways they can be reactive, rather than measuring response to foods that just really statistically had a very low chance of ever being positive. But if you do that, it's helpful to know food family. So this graph, when you see it very far pulled out, then you'll know, okay, that's a family where they're more reactive. And I don't really worry about it too much until you're on this outside ring. I never tell someone they can eliminate the vegetable family. I might add digestive enzymes, but you're not getting off all vegetables. But the ones I find most helpful are the grain and grass family and the fungus family. So maybe somebody comes back, they have reactions, we get them started, we remove things, and then maybe we saw this pulled out to here. Well, okay, so the blue would come out to this level here. And if that were the case, I might say, okay, let's do a low mold diet. Let's do a low yeast diet. That's another thing that there's an example of in our physician guide. So reach out to us and we'll get you set up with that. Or if the food family reached out to here, let's do a grain-free diet. So those are some of the times I use that. And so again, if that's the case, then why did IgG fail to gain acceptance? Well, another reason is because of what standard of care is the question it's seeking to answer. Standard of care wants a test that would lead to a diagnosis. And that's good. We still want that too. Is rheumatoid factor up? Or that points us in the direction of rheumatoid arthritis, right? That's still useful information. But this IgG is general inflammation. That's not a diagnosis, but that's a process that makes most symptoms worse. So for us, we like to know, do you have low nutrition, high toxicity, high mental emotional stress, or high inflammation caused by foods? That process is going to make any diagnosis worse. And so this is one of the reasons. It's not a one food, one condition. And so that is more the perspective of what a lab test should be in standard of care. For us, we want to know what's that process that's making the symptom or the diagnosis worse. And so this is why we've have more utility, why we found more utility in terms of IgG type of reactions. Another pushback can be, does IgG tell a coherent story? Is IgG4 better? Well, we talked about that. That's why you want to tease that out. And then finally, is there data? And there is so much data. If you go to PubMed at this point in time, you find study after study. They're in the slide set, which we'll send out to everybody who registered for the talk. But for example, like I mentioned, different antibodies do different things. These are reactive. This blunts IgG4. Blocks IgE. In our physician guide, you can find a list of these IgG4 conditions, so it's nice to have on your desktop. Also, again, just the data that talks about complement activating reactions. So why did what we do C3D instead of some others out there? Maybe like you might have seen C3b out there. Well, because this is the one that amplifies the reaction. C3b, for example, is further up before the complement cascade has been fully activated. So if you look to see if there's binding here, you could be binding to something before that activation has occurred, and you can get some false positives from that. So we choose to follow what's in the data in terms of what is more inflammatory and not remove foods that patients don't have to eliminate. The nice thing about looking at complement is this is part of the innate immune system. So we're capturing from the innate to the humoral and looking at all those branches of the immune system. And, again, there might be times where we give the complement column more attention. What kind of things are really driven by complement? Okay, well, lupus or psoriasis. So your foods that have complement with IgG, we want to be really quite mindful of in that case. So mentioned the cross-reactivity, things like beef and tick bites. There's a cross-reactivity between pork and environmental allergies to dogs. And like I mentioned, clam and cockroach. And as we see here from the Lancet, also candida and gluten as well. Okay, the patient says, but I never eat these foods, and so what's going on? Well, there can be the case where they create an antibody with the wrong amino acid sequence. We're just not perfect when we make things, and you can make incorrect antibodies that target the wrong thing as well. It's not necessarily the test, but also the fact that we're human and our immune system is human, and therefore it's not perfect either. So here's some of those cross-reactivity between things in the environment and foods. I think they're always fun to look at, not just latex and banana, but avocado as well, papaya, chestnut. Can be kind of interesting. Chamomile and ragweed. So if you ever have a patient that drinks chamomile tea and they're stimulated from that, you might realize, ooh, they might have a ragweed reactivity as well. And so a lot of those things are covered in our Understanding the P88 test results, very thorough guide that talks about these cross reactivities. And we would love to share this information with you. Just quickly, I'm going to fly through this, and then I'm going to turn it over to Jay so he can talk about the promotional offer for being here. But so in the data, when we talk about IgG, so here's a study where they looked at urticaria, right? Classic histamine IgE. And then the people that had no IgE response, and what they found compared to controls, much higher IgG levels than in people with urticaria when there was no IgE present. It demonstrates that there are other reactions out there. IgG, much higher in depression, even higher when there's depression and IBS. And so IgG very much shows up in the depression literature. Migraines, absolutely. You see study after study in terms of IgG. Also think about measuring diamine oxidase. 83% of people with migraines have low diamine oxidase. They can't degrade histamine. And if you see a migraine and IBS together, then absolutely think about food removal. When they did that in this study and removed foods based on IgG reactions, not only did they see their symptoms improved, they saw their serotonin levels go up. And we know serotonin is one of the things you even use to treat migraines. Here, remove IgG in ankylosing spondylitis, and you saw a decrease in reactions, and you saw C-reactive protein go down, proving that there's an inflammatory response. IgG antibodies can create changes in the gut that look similar to celiac. So you see these same interepithelial lesion in that case. And so on as we walk through the data from rheumatoid arthritis to celiac. And this one's interesting, high levels of IgG in celiac, but low levels of IgG4, no tolerance there. So these patterns in terms of what our system is doing, high and IgG and irritable bowel disease. So when people say to you, there's no evidence about this, that is a very dated perception, and there's plenty of IgG data. And we know that even the best allergy test only captures 50% sometimes. So adding these other markers become quite important. So I'm going to go ahead and stop there.